Thank you for the introduction. I'm going to put this take off. Thank you for the introduction. Good afternoon, everyone. It's a pleasure to be here. This afternoon, I'm going to share this presentation with my colleague and friend, Veronica Rico. And we're going to talk about, as the presenter said, the clinical impact of the use of rapid diagnostic tests from two different perspectives, the microbiologist and the infection disease specialist. The content of our presentation started with a short introduction that included epidemiology of urinary tract infection, following by the clinical impact of non-appropriate therapy, and finally a urosepsis protocol. To begin with, antimicrobial resistance, as was explained in previous presentation, has emerged as one of the principal public health problems of the 21st century that threaten the effective prevention and treatment of an ever-increased range of infection caused by bacteria, parasites, virus, and fungi, no longer susceptible to the common medicine used to treat them. This is especially urgent in bacteria. Faced with this reality, the need to avert a developing global crisis in healthcare is imperative. The World Health Organization has long recognized the need of improvement and coordinated global effort to contain this problem. However, it wasn't until April 2014 that this organization published the first reports on surveillance of antimicrobial resistance, collecting information from national and international surveillance networks. The impact of antibiotic resistance in terms of mortality and the public health cost is quite difficult to estimate. The CDC Center of Disease for Control and Prevention in the US conservatively estimate that in the US, more than 2 million people every year are affected with antibiotic resistance. Here in Europe, in 2007 data, was estimated that around 40,000 infections and around 25,000 deaths every year are related with multidrug-resistant bacteria. This is an schematic representation of the factors related with the emergence and spread of antibiotic resistance. We identified 4 main sectors: the medicine in the community, the use of medicine in hospital, animal production and agriculture, and finally the environmental compartment. Different strategies had been developed to fight against antibiotic resistance. One of these strategies aim to improve the healthcare system and laboratory infrastructure, providing equipment, training staff, and facilitated sample collection. The idea of this strategy is to innovate, prevent, and detect.
But why implement a rapid diagnostic test in a urinary tract infections? Because they are the most common infection in the community acquired, and the second one in the hospital basis. And the diagnosis is quite simple. So you have to have a patient with urinary tract symptoms that are dysuria, polyuria, and mictional urgency. And as well, you have to have a urinary sample with a potential uropathogen. It's important because even though everyone thinks that the urinary tract infections are quite simple, quite easy to treat and not very life-threatening, that this is not correct. There are 2 identities that are well differentiated and well identified. The urinary tract infections that are not complicated and the complicated ones. The not complicated are women, not pregnant, not without any immunocompromised comorbidity, without any abnormal structural or functional urinary tract condition, and that doesn't present with a systemic symptoms or shock. So everyone that not enters in this definition, it's a person who with urinary tract infection complicated. And as well, there is another well identified and well described, but not in a real life well managed, that is the asymptomatic bacteriuria. Everyone knows that sometimes a patient, it's made a urinary sample and a urinary test, and you can identify a potential uropathogen, but the patient is without symptoms. And only in a fewer cases, you have to treat them, and most of them you don't need to treat, but it's a common use to treat them, and they represent an important source of the high consume of antibiotics and an important source, of course, of multi-drug resistant pathogens. So it's important to know them, and it's important to identify them. In numbers, there is a study in Canada, a surveillance study that identifies that around 17.5% of patients per 1,000 people have a urinary tract infection. And in our hospital, we are a tertiary care hospital with around 700 hospital beds. We identify more or less 5 episodes per day of urinary tract infections, which are around 1,800 episodes per year. And we have a monographic outpatient clinic that we treat urinary tract patients with recurrent urinary tract infections, and we identify, we treat, we evaluate 4 new cases every week, because we visit one day per week, and we made a follow-up of 15 patients every week as well. And which are the most common uropathogens? All of us know them, but this is a study made during 2016 and 2017 in Spain, the SMART study from 10 different hospitals, and they conclude that the most common pathogens were E. coli, Klebsiella, and Proteus. But more important, they categorize or identify which percentage of E. coli and Klebsiella were ESBL producers, and they distinguish between community-acquired infection or a hospital infection. As you can see, for the E. coli, in a community-acquired basis, 6% of them were ESBL, and 10% in a hospital-acquired basis, and for the Klebsiella, we arrive to levels of almost 30% of these isolates and 35% of the isolates. And as well, we can see, and this graphic that shows something that we already know, that the older the patient, the most probable of having a multi-drug resistant pathogen. Where does live Spain in the Europe map? So we live with a percentage of E. coli of third-generation cephalosporin resistant around 10 to 25% of the isolates. And for the fluoroquinolones that we have already mentioned during the panel discussion, that are the most common, probably used therapy for the urinary tract infections, we have a percentage of from 25 to 50% of E. coli resistance. So we cannot use them as an empirical treatment. And what does it mean not give a patient to the correct antibiotic in a real-life basis? So we have carried a study in 2013. We recollect all the bacteriemic episodes from an acute pyelonephritis from women during 9 years. And an infectious disease and microbiologist disease evaluate every gram strain organism identification in the urinary and in the blood sample, and the infectious disease made the recommendation of the therapy. We follow up the patients during the whole episode of the bacteremia, or until 13 days, or until the death in the hospital, or until discharge. The results, we have collected 2,238 patients. The mean age was 60 years. The main comorbidities were diabetes and solid organ cancer. 89% of them were, sorry, I have moved a little bit, community acquired. 9% of them has shock on presentation on the moment of arrival at the emergency department, and 4% die. As you can see, the most frequent isolated germs were E. coli, as we already know, Klebsiella and Proteus, following the things that we have seen in the SMART study. But as you can see, the impact, the percentage of fluoroquinolone resistance in that moment were 18%, 2% for the ceftriaxone resistant, for the Klebsiella 17% and 10% for the ceftriaxone, and for Proteus 13% of resistant to fluoroquinolones. The main factors associated with mortality were age, having a comorbidity that has a bad prognosis, a healthcare association infection, having shock on presentation, the isolation of a germ that was resistant to fluoroquinolone or to ceftriaxone, but as well, of course, the inappropriate empirical antibiotic treatment. And the risk factors for having an infection that was associated with an AREC strain were previous antibiotic therapy and healthcare-associated bacteremia. So, with these results, what should we do in the emergency department? Should we give to all of our patients carbapenem? Of course, the common sense says not only because it's common sense, it's only because there are a lot of literature reports that shows that the increase of consume of carbapenems increase the probability of the percentage of microbial of multi-drug resistant germs. But as well, we have seen in the real life that maybe carbapenems are not the best treatment to give to patients with urinary tract infections. We have observed when we read the literature from the new antibiotics, the new combinations of cephalosporins and beta-lactams, that most of them use urinary tract infection patients to evaluate the efficacy of the treatment, and most of them, of course, compare them with the best antibiotic in that moment. That more or in the most of the cases were carbapenems, and we have observed that. From a composite cure evaluation, that it's the clinical and the microbiological endpoint, most of them favors the new antibiotic versus the carbapenem, and this especially supports from the microbiological response, saying that when you made the test of cure, when you made the urinary culture after finishing the antibiotic around between 7 and 10 days after finishing the antibiotic, in most of the cases, when you don't give the carbapenem, the patient has eradicated the pathogen, but when you give the carbapenem, the pathogen was still there. Which are the causes for them? We don't know that. We hypothesize that maybe carbapenems have more effect in the anaerobic flora, and this could reduce the barriers that we have to prevent to have another uropathogen in your urinary tract or maybe in your flora vagina.
According to this, therefore, a rapid diagnosis improves the management of patients, especially patients with sepsis, because, as Veronica explained, inappropriate antibiotic therapy has an important impact in the patient outcomes and in the mortality rates. This corresponds to the NG test that we are related. The first one related with that allowed, a rapid detection of prevalent CTXM groups, and the second ones that allowed a rapid detection and differentiation of the 5 types of carbapenemase. This corresponds an overview of the results related with our experience with direct identification using the MALDI-TOF and the application of the NG test from patient of the emergency rooms, patient with bacteremia and sepsis from urinary source. On the next slide, I will comment on these results. The conventional protocol that we use to process the urinary samples in our lab included a screening with a chemistry analyzer, the Clinitect, and the quantitative culture on clad agar for 24 to 48 hours at 36 degrees in aerobiosis. We achieved the identification, the final identification with MALDI-TOF, and after that, according to MALDI results, we performed the antimicrobial susceptibility testing. The new workflow. The objective was elaborate a protocol to a rapid processing of urine sample, combine the flow cytometry technology plus direct identification with MALDI-TOF. In this case, we compare this new workflow with a conventional processing in our lab routine, and according to direct identification of MALDI-TOF and according to our local epidemiology, we applied the NG test. And this result of the NG test were compared to the antimicrobial susceptibility testing of the routine that we use in urine sample, in this case, the method of disk diffusion, and the interpretation are according to the EUCAS guidelines. Why flow cytometry as a screening? Yes, MALDI-TOF is a promising technique for direct identification from clinical specimens, but as another technique had some limitations. First, we need a high concentration of bacteria for obtain a valid protein spectrum, and second, a sufficient sample volume is necessary, and in some cases is critical from some types of biological specimens. For that, we use a criteria a concentration of bacteria. In this case, that was major or equal to 5,000 bacteria microliter, and we use an advantage of flow cytometry that allowed a bacterial differentiation represented using an scattergram. In this first picture, we can see a bacterial distribution that follow around 30 degrees angle, and this corresponds to a gram-negative bacteria. When the distribution of bacteria follow in between 40-45 degrees angle, this corresponds to a gram-positive bacteria. In this second picture, we can see two populations of bacteria, one represented with the pink color and the other with a white or gray color. In this case, this is probably a mixed culture or a contamination of the urine culture, and in these cases, we don't follow with the new workflow with the direct identification with MALDI. The direct identification that based in MALDI-TOF is we use a centrifugation-based procedure to use a direct, as I said, a direct identification with MALDI, and after this centrifugation, we use the pellet in the plate of the MALDI-TOF, and we analyze in duplicate analysis of the samples. And we follow the manufacturer recommendation, and we only obtain a reliable identification when the score was major or equal of 2. According to epidemiology, multi-resistant bacteria, when MALDI-TOF gives us a reliable identification of E. coli, we apply the NG test to detect a rapid detection of the CTXM. In the case of Klebsiella pneumoniae, we apply both tests, the CTXM and the carbaphyl. And in the case of Enterobacter cloacae, we apply only the carbaphyl. As I said, this is a rapid test. In only 15 minutes, with the pellet that we use to MALDI, we use it in this NG test, and in 15 minutes, we obtain the results. When we obtain the result of the flow cytometry and the direct identification with MALDI, and there were reliable results, we validate this result in our lab informatica system, and in parallel, we inform the clinician in charge. This corresponds of our results in the first study. We included 298 urine samples. All the patients were from the emergency rooms, and for that were patients that suspicious of bacteremia or sepsis, and in this case, we took a blood culture in parallel. This corresponds to the sample inclusion criteria. This was the time frame of the samples that were included, the reception of the sample in the study. The urine volume was an important criteria too. As I said, this is a limitation of MALDI. We need volume. And the flow cytometry criteria, as explained before, the high concentration of bacteria and the scattergram results. Of the 219 samples, the samples that met the flow cytometry criteria were 86 samples. In the blue post, we can observe the result of the culture. We obtained 1 negative culture, and 78 positive culture, and 7 contaminated culture. Of the 78 positive cultures, we obtained with direct identification with mildly 54 concordant results, 1 discordant result, and in 23 cases, we are able to achieve the result of direct identification with mildly tough. This corresponds with the results. We identified 30 E. coli with a score measure of 2, and in comparison with the culture results, in the culture results, they were in agreement with in 27 cultures. In 3 other cultures, we identified E. coli plus another microorganism. This happened in Klebsiella pneumoniae 2. We identified 10 Klebsiellas with direct mildly tough. In the culture, we identified and were in agreement in 8 culture samples, and in 2 other, we identified Klebsiella plus another microorganism. In Pseudomonas aeruginosus, was the same theme. We identified 3 with direct identification, and in the culture, we identified 2 and 1 mixed culture, Pseudomonas plus another. This is the rest of the identification results. With the rest of the microorganisms, we have an agreement with the culture result, except for 1 case, when Enterococcofaecium, direct identification only identified the Enterococcofaecium, and in the culture we identified this plus Enterococcus faecalis. As I say in previous slide, we don't achieve a reliable identification in 23 cases. We have a discordant case where direct identification result was an E. coli. In the culture, we identified 3 microorganisms and was considered as a contamination. In the case of the flow cytometry, where the result, the account was minor of 5,000 bacterial moleculators, we identified 212 cases. In these cases, 36 correspond to positive cultures. Of these 36, 22 have a bacterial account minor of 10 to 5 colony-formant unit. Of the concordance result of the mildly tough compared with the culture, we applied the NG test in 30 cases, and the agreement of the NG test with the antimicrobial susceptibility testing of our routine was the 100%. We only identified CTXM in this first study, 6 in E. coli, and 4 in Klebsiella pneumoniae, and as I say, we didn't detect any carbapenemase.
So what does the clinician with these results? So they send us an email with the number of the patient and with the result of the rapid identification, and we evaluate if the patient has an urinary tract infection, and if it has it, we evaluate which are the treatment that he or she is receiving, and we direct this treatment according to the identification. So for our results from the 36 NG tests performed, 38 were cases, for the 54 ED cases, 38 cases were receiving appropriate empirical therapy. In 7 cases, we have made a step down in the antibiotic treatment. The step down, I mean, for example, they were receiving meropenem, and we identified an ESBL E. coli, so we escalate to ertapenem. And in 8 cases, we adjust the treatment. For example, we change ertapenem to ceftriaxone, or and vice versa. In overall, we have reduced the consume of carbapenems because it's the most frequent antibiotic given in our hospital in a urinary tract infection basis of 7.4% of cases.
Related with the blood culture results, as I said before, we took the sample in parallel with urine samples, and in this case we obtained 27 positive samples. Of these 27, 14 we achieved a direct identification from urine source, and in 8 cases no reliable identification was achieved with the urine sample, and in 4 of them they don't met the flow cytometry criteria, and 1 was a discordant case. With these results, we decided to implement this new workflow in our lab routine. And this is our experience of the first 6 months of the year. We included not only patients from emergency room, also hospitalized patients. We included in these 6 months of experience 122 samples from 120 patients, and we identified 6 gram-positive bacteria that were in agreement with the urine culture and 116 gram-negative bacteria. We correct identification using the direct MALDI in 96 cases, in 5 cases where we obtain a contaminated culture and 40 mixed cultures. Related with the NG test results, we don't perform these NG tests in 16 cases. We obtained 74 negative tests. We detect 27 cases of ESBL and 2 cases of CARVA in 2 Pseudomonas aeruginosa, 2 Pseudomonas putidas, 2 VIM, and we detect 3 cases of Klebsiella pneumoniae with an ESBL plus a CARVA. In this case, were 2 with an ESBL plus OXA48 and 1 with ESBL plus a VIM. In summary, flow cytometry, the combination of flow cytometry and MALDI-TOF for direct identification reached a high agreement with urine culture, and with our results and the currently implementation of the new workflow, we can say that lateral flow assay for ESBL and carbaphenamase has an important clinical impact. This is only to remember that the last week was the Antimicrobial Awareness Week, and this is a continuous fight, and we need to continue with the research, and we need new molecules, and that's it. Thank you so much for the attention.